Hello.
Hi, everyone. This is Tanya Winder, the nurse practitioner from Temple Lung Center with the Sarcoidosis program. We are so excited that you're here to join us today for our Sarcoidosis seminar. We're going to actually wait just a few more minutes. We're going to go ahead and get started. Once again, my name is Tanya Winder. I'm one of the nurse practitioners here at the Temple Lung Center. And I will be hosting your sarcoidosis seminar today. We have a lot of great things for you planned today in honor of this sarcoidosis month. In preparation for this seminar, it's going to be from 2 to 4 p.m. So I need all of you guys to make sure that you're muted and your cameras are off. But please feel free to chat, ask any of the questions you may have at the box at the bottom of your Zoom screen. At the very end, we will actually have a question and answer period that you will have with the panelists or whoever is there. Of course, I will be with you throughout the event, so I will also be able to try to answer as many questions as you may have. Quickly, if we can go to the next slide, just to give you a quick overview of our agenda for today, we will be discussing how sarcoidosis can affect the different organs in the body, such as the lungs, the heart, the kidneys. A pharmacist to discuss with us the different medications that are used to treat sarcoidosis, as well as the different medications that might be used to treat COVID-19 if you have sarcoidosis, as well as we have a specialist that will discuss from a rheumatological point of view, the way sarcoidosis affects the body all over. Now, just moving forward so that we can stay on time, we are going to have our very first speaker, Dr. Rohit Gupta. Dr. Gupta is actually the director of the sarcoidosis program here at Temple University Hospital. He is an associate professor here through the Thoracic Medicine and Surgery, Lewis Katz School of Medicine. So if I can just have you, everyone, just welcome Dr. Rohit Gupta as he goes forward to present how sarcoidosis affects the lungs.
Hello, everyone. Can everyone hear me well? You guys can hear me, Tanya?
Yes, we can hear you.
Awesome. All right. Welcome, everyone. Thank you for being a part of this patient symposium as a part of our Sarcoidosis Awareness Month activities. I am going to quickly talk about sarcoidosis in general and also how sarcoidosis affects the lungs. And this is a quick overview. Please feel free to ask questions after the end of this presentation or towards the end when we all meet as a panel discussion. Let me see if I can. Yes, I can. Okay. All right. I can make the slides forward. Good. Okay. I have no disclosures. We'll talk a little bit about the medications, but not too much. And as many of you know, that most of the medications are off-label for use in sarcoidosis, so that would come up. So really quickly, when we talk about sarcoidosis and the presentation of sarcoidosis, this is interesting because if you look at one patient with some symptoms who has sarcoidosis versus the other one, it is very different in presentation, and it is very different in really how it goes forward in its natural history. So the same disease phenomena, if we are not really opening ourselves to the whole patient, whole picture, we might be looking at, oh, this is X disease, this is Y disease, but sometimes we have to open up and make sure that we are talking about a disease which is multi-system based, meaning it can involve multiple systems of the body. This disease is very old, yet remains enigmatic. We have to still learn a lot about it. It is a systemic disease, meaning it can involve multiple organ systems of the body. Lots of variations and unpredictability mars the progress of the disease in the field of the disease. But essentially, what happens is we really have to see what the disease is doing in a specific patient to kind of see how they will progress and how else we can help these cases. And it is found throughout the world in all the age groups, both the sexes, all the ethnic groups, but there are variations, and many of you know that 20 to 40 age group is generally the age where we diagnose it the most. Women and African American race is actually more affected, and African Americans have actually little bit more chronic of presentation and how the disease can actually get worse in the future. When we talk about the pathogenesis, why it happens, we are still feeling that it is in the setting of a genetically predisposed host when they are exposed to antigens which can trigger this exaggerated cellular immune response or inflammation. It leads to formation of granuloma, which is essentially what is depicted in this picture, that there's some sort of agent like infection, organic particle, or inorganic agents. And this is unfortunate that we don't have a set uh, number of things which can lead to this. But the thought is that multiple agents, which are yet to be identified, can start this inflammatory process, which ultimately leads to this granuloma. What are granuloma? These are tightly bound clusters of cells, where essentially what the body is trying to do is to wall off this trigger inside this ball of inflammatory cells. And as we are seeing here in this second picture on the right, these are tightly clustered balls. These are called non-caseating, meaning they don't have necrosis or caseation in the center of these, which helps us as clinicians to differentiate it from infections. It is granulomatous, as we just talked about. These are granulomas, and it is inflammatory condition. So moving on to pulmonary sarcoidosis, which is the major part of the talk now. Pulmonary sarcoidosis, we know that more than 90% of the cases with sarcoidosis involve the lungs or the chest wall area. Not chest wall, the chest area, including the lungs or the lymph nodes. And the pulmonary sarcoidosis phenotype accounts for most of the morbidity, mortality, and healthcare use in the field of sarcoidosis. There is a delay in diagnosis and misdiagnosis both, because the clinical features are non-specific. Many patients can present with cough, shortness of breath, wheezing, and many times they are mislabeled as symptoms of COPD or asthma. We really have to be careful, because as we talked about, this disease can be non-specific, and we have to kind of overall see the whole picture and see whether we are dealing with sarcoidosis. When we do breathing tests, which is called pulmonary function test, PFT, generally we find restrictive defect, meaning the way the lungs expand, they are not able to expand completely. And decreased diffusion capacity can be also seen when the diffusion across the blood and the lung barrier, the alveolus, which is the functional unit of lung, that diffusion is not well as well sometimes. But it is interesting that we have to be careful. Any pattern and even normal PFT is possible in cases of sarcoidosis. When we talk about diagnosis, if we are doing a bronchoscopy, which we'll talk about in a second, bronchoscopy is very high yield for diagnosis, and sometimes we add on an ultrasound, which is called endobronchial ultrasound, and we do some procedures where biopsies are taken either of the airways, which are called endobronchial biopsies, or transbronchial, which are lung biopsies through the bronchi or through the airways. I'll show you some pictures here to kind of get to that. So this is a bronchoscope. If you can see my cursor, and it goes through the nose, or if we put the breathing tube in the throat, it goes through that tube, essentially going into the airways, and then we kind of look at the airways and go inside the lung tissue itself. Many times we actually use fluoroscopy, which is X-ray, and we guide a forceps through this bronchoscope to the lung tissue where we want to take a biopsy from. Now, this is the ultrasound bronchoscope, which is called endobronchial ultrasound. So this is a different type of scope. This bronchoscope is thinner. This one is a little bit thicker. And this probe here is ultrasound, and we can touch the wall of the airways and then look at the lymph nodes to give us a real-time lymph node biopsy. And this is how the picture looks when we are doing the procedure, and we can see the needle going into the lymph node for preventing any type of complications, etc. Now, when we talk about chest X-ray, imaging is very important in sarcoidosis patients, and this classification sometimes is called scadding staging. Staging term itself is misnomer because you don't have to go from stage 1, 2, 3, 4, but the staging is useful indeed for rates of resolution. So stage 0 or 1 have high rates of resolution, but if you're stage 4 X-ray findings, then the resolution does not happen. Fibrosis, once it happens, it is fibrosed. The scarring does not resolve. So, and in the panel A, we only see lymph node enlargement here, which is stage 1, only lymph nodes seen. Stage 2 is B, where there are some lymph node enlargement here, and then there are lung parenchymal changes as well. C is kind of similar, where you see lymph node enlargement as well as lung findings. D is where you see only lung findings, and E is where you see stage 4 or fibrotic or scarred lungs, where you see the pull on the lung, and the lung volume reduces. Lungs essentially kind of shrink a little bit. They are pulled by the traction on them. Nowadays, everyone has a chest CAT scan when they come to our clinic, mostly for second, third, fourth opinions. And we can see multiple patterns. We can see as subtle abnormalities as in this slide, you see very small dots or nodules. You can see more dots, much more visible and much more prominent, if you will, on both sides of the lungs. We can see sometimes these kind of nodules come together and look like nodular densities. And sometimes these can even look like even more bigger areas of consolidation itself. Now, as the disease advances, we can see fibrotic changes. These are lungs which are scarred, and you see a lot of dilation of the airways and the pull on the airways as well. So those are the chest CT. Now, many times patients ask us, what will happen to me once I've been diagnosed with this disease? And this is a fairly tricky question because it all depends on how the disease and the patient is interacting. And this is a little bit complicated graph, but we're going to go through this. This is actually very interesting if you will bear with me. So as the legend, yellow is inflammation, green is treatment, and blue is fibrosis. So some patients can have, and also on the x-axis is time in years, and on the y-axis is how the patient is evolving. So first, if we see, some patients can have inflammation, which either resolves itself or with treatment. So in the first, the number one scenario could be the inflammation happens. It was either undetected, or the patient felt something but didn't really need treatment or didn't get treatment, and the disease resolves and does not come back. Number two is where there was inflammation, treatment was given, it was stopped, and nothing else happened ever. Third is there is inflammation which is going on, but patient is not very drastically affected, never got any treatment. Fourth, they get these relapsing, remitting courses of treatment because of inflammation. Fifth is where inflammation keeps on going. You keep on going treatment after treatment after treatment, but you still can't treat it. Sixth is where you have some fibrosis and this relapsing, remitting type of picture. Seven is where there was inflammation, nothing major going on, but then the fibrosis takes off. And you're trying to treat with anti-inflammatory regimen, but it's not going to work because inflammation is not the problem, fibrosis is. And then eighth is where there is fibrosis, which doesn't really bother the patient. So different presentations can happen, and we have to know what will happen to that patient. It is difficult in the beginning, but some of the features which can predict poor prognosis or later course are if the diagnosis is later, age more than 40, African American race, extrapulmonary disease, if the patient requires treatment, or if they have advanced pulmonary disease itself. When we talk about advanced pulmonary sarcoidosis, whenever we talk about advanced in the field of sarcoidosis, it is a disease with significant risk of death or loss of organ function. Advanced pulmonary sarcoidosis is that phenotype in the lung sarcoidosis. 5 to 20% of the patients with sarcoidosis get affected, but this phenotype is the one which which impacts the mortality and morbidity the most, and it consists of advanced fibrosis, pulmonary hypertension in the setting of sarcoidosis, respiratory failure, and other infections. Now, some people can get exacerbations when they have sarcoidosis, or their inflammation can be refractory as well. Now, whenever we see a patient with pulmonary sarcoidosis or advanced pulmonary sarcoidosis, and they have new or worsening symptoms, I'm not going to go through this table completely, but why this table is here is to kind of understand that this is a multi-system disease. Any symptom which is a new or worsening symptom in these patients, we have to be cognizant that it could be worsening of the pulmonary sarcoidosis, could be a development or worsening of extrapulmonary sarcoidosis, could be complications related to treatment, or it could be others which might or might not be related to disease or treatment. So again, needs a holistic view to see what we can do. When do we treat patients with pulmonary sarcoidosis? We treat when they or the organs are in danger, or when there is a severe quality of life impairment. Diagnosis itself is not enough to initiate treatment. We want to regress the disease, stabilize the disease, or prevent complication depending on the scenario. And there are cases where we say, you know what, we are just going to monitor, we are not going to do treatment, but those are the patients where their symptoms are less, their organ function is not in danger, they don't have active disease based on inflammation and all, and their chances of remission are more. Now, once we have decided we are going to treat, steroids versus steroid sparing agent becomes the problem. And I choose steroids only when I feel that it would be a short course, patient does not have too much comorbidities, it's a recent onset, and it's a responsive organ. There are other treatment available. Again, glucocorticoids, which are the steroid-sparing agents, including methotrexate, azathioprine, leflunomide, mycophenolate, and then biological or advanced treatments are there. We always assess for the progression and medication side effects, aim for the lowest steroid dose, and we might have to try to start combination therapy if there is a severe disease. Some of the examples of medications, the doses, toxicity, and monitoring. I'm not going to go into that in detail, but again, we have to make sure that we understand that everything has potential side effects and we are carefully monitoring that. Finally, patient care, research, and education form the multidisciplinary core of the center. WASOG, which is the World Association of Sarcoidosis and other granulomatous diseases, centers of excellence and clinics, which we are fortunate to be a center of excellence. And we take pride that we have a defined team of specialists, algorithms for management and diagnosis, patient support group, educational activities like this one, and understanding the disease better with registries, collaboration, and advancing literature on the disease. That's what we are trying to do. So I'm going to leave you with these take-home points. Essentially, multi-system disease, immunological basis, pulmonary disease is the most responsible for morbidity and mortality. We need multidisciplinary approach, and establishing collaborative research and centers of excellence are critical in the progress of this field. With that, I thank you all, and will ask you if you have any questions later or whenever Tanya wants. Thank you.
Yes, thank you so much, Dr. Gupta, for that very wonderful talk on pulmonary sarcoidosis. We learned so much about who sarcoidosis affects, how it affects the lungs, and how it's diagnosed. But we are going to go ahead and move forward with our next speaker, and hopefully you'll be available for our panelists at the end of this seminar.
Yep.
So we have Noor Kazi, who is going to be discussing medications to treat sarcoidosis and COVID-19. Noor is actually a clinical pharmacist specialist specializing in pulmonary medicine, lung transplantation, and rheumatology. She actually has her doctorate of pharmacy practice here from Temple University School of Pharmacy, and we are so excited for her to be doing this presentation on the medications that are used to treat sarcoidosis. Noor?
Okay. I need the host to put my camera and start video. Okay. Okay. All right. So perfect. Thank you for the introduction, Tanya. It's a pleasure working with everyone. I'm going to go ahead and first I'm going to look at sarcoidosis as far as the medication perspective, which Dr. Gupta kind of started at the end of his presentation. And then I'm going to go ahead and we're going to do 3 of the outpatient treatments for COVID, since that's a hot topic nowadays. So we're going to go ahead and advance the slides. So, like Dr. Gupta said, that we're not going to treat every patient that just has a diagnosis of sarcoidosis. If the patient has symptoms and it is affecting their quality of life and it is affecting other organs, then that's when we treat these patients. So there are different symptoms of sarcoidosis, and I'm sure Dr. Gupta already went into this, so I'm not going to go ahead and go through this. So now we start with the different treatments. So one of the first treatments is inhaled steroids. So those are a lot of the inhalers such as budesonide, fluticasone, mometasone, or prednisone orally. So those are the corticosteroids that Dr. Gupta was discussing. The next step is they would look at a patient's chest x-ray to see what the PFTs are looking like, and those are the pulmonary functions tests. And depending on the values in the pulmonary functions test, the providers will decide whether or not to continue the treatment. And then they're going to go ahead. After prednisone, we will look at other drugs. So we're going to go on the different steps of the drugs. So the first one is the steroids, which we already discussed. Depending on the patient's response, they'll go ahead and proceed with the steroids and lower the doses. So now the inhalers. These are some of the inhalers. There are so many inhaled corticosteroids. We're only going to go into some of them. So the indication for those is the actual symptom treatment of the lung manifestations of sarcoidosis, such as the cough, breathlessness. And then the inhaler will be given to these patients. These are some of the doses of 2 of the inhalers and some of the side effects. One of the most important things to do with these inhalers is to always rinse your mouth out. So the patients will go ahead and take the inhalation, but afterwards you're going to rinse it out with either warm water or mouthwash. And the reason why we do this is because one of the side effects that these medications can cause is oral thrush. So that's basically some type of fungus growing in the mouth, and we prevent that by flushing, by rinsing our mouth out after you take this medication. And there are some less common side effects. I know a lot of patients present a concern. They're like, oh, well, this affects my glaucoma with these inhaled steroids. It's a very low chance that that'll actually happen. These are local medications, so it'll literally get just to the site of action, which is that lung tissue. So here's a diagram of some of the inhalers. There are more of these inhalers, but the corticosteroids are the main ones that will be used for sarcoidosis. And as we know, steroids act against inflammation. So whether it is oral or inhaled, now we're going to discuss the prednisone. So the prednisone doses actually range depending on the patient and, like we said, their response. So some of the side effects, some of the ones that patients most complain about, are some patients might have difficulty sleeping. A lot of patients gain weight. Your blood pressure can increase, your blood sugar can increase, and with a decent amount of steroids, it can lower your immune system to increase your risk for infections. And eventually, enough steroids can actually weaken your bones and can cause osteoporosis. So if a patient has been on steroids, many times the provider will order bone density checks to make sure their bones are good. So what you're going to monitor for is you're going to look at your blood pressure. Well, actually the providers as well, they'll take your blood pressure, they will see your weight. And if you've gained a lot of weight on the steroids, some providers will take it back and say, okay, maybe we can decrease the dose of your steroids and still have enough control of your sarcoidosis. Sugars, if the patient has blood sugar issues or if they develop diabetes because of the steroids. So now we're going to go ahead and talk about controlling some of the side effects of the steroids. So if the patient has increased sugars, they're going to monitor them. They might refer you to an endocrinologist, which is a doctor that looks like hormones and your sugars. They'll also look at your blood pressure, and so they'll monitor your blood pressure. The provider will monitor your blood pressure. And then this medication can cause bone loss. And that's why we do these DEXA scans, the bone scans. And a lot of providers will recommend vitamin D for the patients. So they know that this medication can weaken your bones. So they recommend calcium and vitamin D for the patients. So now, if you have to take steroids. Oh, wait, what just? I'm not sure what's going on with the slides.
Hold on just a second. Let me control the mouse. I'll get your presentation right back up for you.
Okay.
Thank you.
I apologize. Okay. So what if you have side effects that you don't like, that are not tolerable, that are affecting your quality of life from the steroids? Okay, so what providers will do is they will see the prednisone and they can add another drug onto it. So one of the types of drugs that we can add are cytotoxic drugs. So these are drugs that work in a different way than the prednisone, and we kind of have each of these medications work in a separate way so that to decrease the side effects of your steroids. So we'll have one drug working in one part of the body and another drug working in another part of the body to help decrease those side effects, those unwanted side effects of the prednisone. So one of the first cytotoxic drugs is methotrexate. This medication is given weekly, 5 to 20 milligrams, and the providers might start at 5 and then they will go up by 2.5 milligrams weekly to see what the patient can tolerate and control their sarcoidosis. Some of the side effects are diarrhea, nausea, and vomiting. Another side effect that we might not see is some of the liver problems. So the doctors get these measures called your liver functions test. So we actually look at your liver to see how the medication is going through. And if your liver functions test become higher, the doctors may decrease the dose or change the medication. This medication can also cause different lung problems, skin reactions, and may also increase the risk of cancers. Since this is a cytotoxic drug, so cytotoxic means that it can actually harm cells. We technically want it to only go after certain cells. So another side effect, more into the side effects of these. So sometimes the providers split the dose. They'll say you can take it every 12 hours. To decrease the liver disease from methotrexate, we can actually add another vitamin called folic acid, and they should not be used in patients who are pregnant. These are the other cytotoxic medications that can be added for a patient, and the side effects are listed next to them. And of course, we're going to do monitoring for these medications. And your provider will not only monitor you, they will send you for labs as well. So now there are other medications other than the cytotoxic medications and the steroids. These medications are tumor necrosis factors, and they actually go against specific cells and target them. Now, one of the first ones is Remicade, and these medications can be given as infusions, and your provider will set you up for that particular care. These medications can cause increased risk for infections. They can actually worsen heart failure, and they can increase your risk for cancer. And a lot of these patients, we will screen you for tuberculosis before initiating this medication, since it can increase the risk of infections. So here's all of the different medications actually listed for you here. I know it's a lot of medications, but your provider will discuss your medications and the options as you go through. So now here are some resources for patients to have support for these medications, and if you want to learn any more about these. So that's it for the sarcoidosis medications. I can start one of the main medications for COVID treatment. I'll do just the treatment option. So we'll go ahead and just go to the one treatment option. So Paxlovid is one of the medications that's actually available at different pharmacies, maybe not your local pharmacies, and it's actually to treat COVID-19. It's the highest recommendation. The one issue with this medication is it does have a lot of drug interactions, and it comes in a little blister pack. So it'll say morning and night. So as you can see, the morning of blister pack, you take all those pills at once, and then in the night, you take those pills in the evening. And you must take this medication within 5 days of symptom onset. And some of the side effects of this medication, it can increase your blood pressure, it can cause muscle pain, diarrhea. And the one that I've heard most was the patients complain about disruption in their taste. They're like, it just gave me weird taste afterwards. And for the drug interactions, most of the providers actually ask a pharmacist, or you can ask the pharmacist to make sure that these medications actually don't interact with your current medications. And that's really one of the mainstays for a lot of patients who are at risk for having worse outcomes with COVID. There is a medication called Evusheld, and Evusheld helps give you more protection. It gives antibodies against COVID, and this is indicated for patients who are immunosuppressed, may have cancer, have been transplanted, or patients who in general did not respond to the vaccine. The one condition to get this medication is that you must be vaccinated, but it prevents severe COVID. And that's it.
Thank you so much, Nora, for that wonderful talk on the different medications that are used to treat sarcoidosis. Because with having sarcoidosis, it's good to know what kind of medications that you're taking, how it might affect you, as well as the different medications that are used to treat COVID-19. Of course, Nora did not get a chance to review all the medications, but she did review one of the medications that are key in the sense of being able to treat by mouth if you were to develop COVID within 5 days. I'm going to ask if everyone could, and it looks like our next speaker has joined, and our next speaker is Dr. Roberto Carriccio. He is the chief of the section of rheumatology, a professor of medicine, also a professor of microbiology and immunology. He's also the director of the Temple Lupus Program. Today, Dr. Carriccio will be discussing how COVID affects patients with sarcoidosis. Thank you so much for joining us today, Dr. Carriccio.
Of course, of course. Thank you for having me, and thank you for everybody else to participate. So I don't have any slide. I wanted just to have a conversation with the patients and those that participate, and hopefully have in the conversation list what is of a concern for patients with sarcoidosis when it comes to COVID-19. And I assume that I'm seen correctly and I'm heard correctly in the Zoom platform. So I was thinking about it and say, if I were a patient, and probably we should, as physicians, we should do this exercise more often. But anyway, if I were a patient with sarcoidosis, what would I like to know when it comes to COVID-19? Well, the first question that would come to my mind if I had sarcoidosis is that, is COVID-19 worse in patients with sarcoidosis? Because, that would be a good thing to know. And so based on that question, what we would do and what I did was to look at the literature. What does the literature say? We do have a certain experience, and my colleagues in pulmonary do have a certain experience with patients with sarcoidosis, because we had so many patients with COVID that by chance, very few of them had sarcoidosis as well. So the answer, based on the large numbers of case series reported in the literature, is no, and it depends. So meaning no, it doesn't appear to be worse, COVID-19 pneumonia in patients with sarcoidosis, as long as their lung disease is not significantly advanced, which is not in everybody, but in a fraction. So, but that is the same thing for any other individual who has a significant lung disease, very advanced, and therefore, even in these individuals, if they have a normal pneumonia, that might be a problem. So in general, the answer is actually no, it doesn't appear from those studies. Now, granted that there aren't that many studies that looked at very large numbers of patients with sarcoidosis who happen to have also COVID-19 pneumonia. And these, of course, these data are data that have been published largely from cases that occurred before the widespread availability of vaccination. So as the first question is, no, it doesn't appear to be worse. So do you have to worry about COVID-19? Yes. But do you have to worry more because you have sarcoidosis? Not necessarily. And I hope that was helpful. Now, also as a patient, what I would like to know in case I get COVID-19 pneumonia, and if I have sarcoidosis is, well, if I have sarcoidosis and they have to give me treatment, can I get the same treatment that other patients might get because they have COVID-19, but they don't have sarcoidosis? In other words, does the treatment for COVID-19, and now we can do quite a good job, impacts patients with sarcoidosis because they can get that particular treatment? And I hope that is an important question for you. Well, the answer is no. If you have sarcoidosis and happens to contract or be infected with COVID-19 pneumonia, you would most likely receive the same treatment that patients without sarcoidosis have. And so early treatment with a certain amount of steroids, but also certain medications that block the reproduction of the virus, remdesivir in particular. And you would also get medications such as baricitinib, which is a medication that we actually use in rheumatic diseases, which works pretty well for certain rheumatic diseases, but it appears to work pretty well also in COVID-19. So you would take the same treatment, and these treatments really depend on the level of severity of COVID-19 pneumonia, because you can imagine we are talking about patients that the severity goes from not knowing that actually you have it, only based on a PCR test, to actually be in intensive care unit. And everything in between. So there is an enormous variability. But in general, treatments that would be offered as a standard of care to patients with COVID-19 without sarcoidosis would also be offered to patients with COVID-19 and sarcoidosis. So the impact is relative. So this is also, I think, good news. Of course, you should still stay away from COVID-19. You don't want it just because you can get the medications. But in case you get it, then the treatment would be very similar, and there would be the same standard of care. One more question that I thought could be, as a patient, I would like to know is that many of, quite a number of patients with sarcoidosis are taking medications that are immunosuppressive. And so theoretically, the COVID-19 could be worse in those patients. Now, it depends on the immunosuppressive status, and also the fear was much more prominent, much more present before the vaccination. After vaccination, medications that do immunosuppress, they are of a concern for sure, but much less, providing that the patient is, the individual is vaccinated. But in terms of medications that might impact and make worse the COVID-19, one of them, for example, is high dose of steroids, meaning that those patients should take very high levels of prednisone or prednisolone or steroids in general, because they need that for their sarcoidosis at the moment, might be a little bit more at risk of having contracting, being infected with COVID-19, because steroids could do that. Nevertheless, the good part is that one, there are the vaccines, which will answer to that question last, and two, there are other medications that can nevertheless help control the pneumonia. There are medications that patients with sarcoidosis use and are immunosuppressive. One in particular at times is called Rituxan, which impacts the way that we make antibodies against infections. That one might increase the risk of the severity of COVID-19. But again, one approach is to stop that medication once the COVID-19 pneumonia is diagnosed, and use the same protocols for treatment of COVID-19, regardless if the patient has sarcoidosis or not. And as I mentioned at the beginning, all of this is true, providing that this patient does not have significantly advanced lung disease, which is only in a fraction of patients with sarcoidosis. Many others don't have significant problems with their lungs. So as a due diligent, the physician, when encounters a patient with sarcoidosis, but above all with medications that the patient is taking that are immunosuppressive, takes that into consideration, generally speaking, stops them, and then start the proper treatment for COVID-19 pneumonia, and only for a brief period of time, anywhere between 10 days to 2 weeks. And then the medications that the patient was taking before the COVID-19 for sarcoidosis should be restarted. So there might be an impact on the medications, but it's only for a short period of time. And so the last question that I would like to know, if I had COVID-19, I mean, if I had sarcoidosis, and when it comes to COVID-19, is that do the vaccines work if I have sarcoidosis, vaccines against COVID-19? Well, also good. In that case, the answer is yes. They do work in patients with sarcoidosis, as far as we can tell, as much as patients without sarcoidosis. Now, I want to disclose that we in terms of scientific society and healthcare providers, we take that as a bit of an assumption, because there isn't really a large case study in patients specifically with sarcoidosis, but we extrapolate from patients that have different rheumatological and autoimmune diseases, and we saw in those patients that there was no difference. Those patients responded wonderfully to those vaccines, and therefore we assume that patients with sarcoidosis do the same. The only aspect to make sure to take care of is to see what medications those patients are taking, patients with sarcoidosis and other rheumatic or autoimmune diseases, and making sure that they are not preventing the patient from mounting an immune response to the vaccine, because there are those medications, those that specifically immunosuppress. And so there are guidelines to follow for those, because there are studies that we also participated. And generally the approach is to, depending on the medication, and for that you should ask your doctor that is giving you those, they are held 1 week before. So for one dose before and 1 week before and 1 week after, generally speaking, some just 1 week before getting the vaccine or getting the booster, except for one, which is the Rituxan that I mentioned before. And the colleagues that are giving those medications, they know well. There has to be some timing in between the infusions, which often happen every 6 months. Other than that, usually is a brief holding of the medication just around the shot or the booster, and that ensures a good response to the vaccine. So the answer is yes. The COVID-19 vaccines work quite well in patients with sarcoidosis. And I hope those 4 questions were satisfying, or those are the questions that as patient you would have asked yourself and wanted to know. Yes, no, I think I finished with my 4 questions that I thought I wanted to answer for the patients. But if the patients have a question, I'll be happy to respond.
Okay, great. Thank you so much, Dr. Caruccio. Did anyone have any questions for Dr. Caruccio? Because he actually has a couple minutes left in his talk before we go to break. Any questions?
That was great, Roberto. This is Rohit. Just quick question. So for rituximab and vaccination, what exactly was the time frame you gave?
Yeah, so there has to be timed after the last infusion. So 2 months after the last infusion to have, if possible, if that's the time frame, to allow the reconstitution of B cells, and then attempt to boost in that time frame. And also, I would check the level of antibodies at least a month after the booster to make sure antibodies against COVID or SARS, to make sure that the actual booster worked. And in particular, in patients with these Rituxan, they should really go for sure through the 4th booster, if not the 5th booster, if there hasn't been an appropriate response. And of course, there is also Evusheld, the combination of monoclonals that would protect the patient for quite some time.
So if the patient got rituximab in December, ideal time frame would be 2 months after, so February end or something.
Yes.
Then get a booster in March.
Yes, and I would consider also Evusheld.
And then in June they will get rituximab again.
Yeah, because for some reasons that are under investigation, Rituxan seems to be the one that is it's the one that gives more resistance to the production of antibodies.
That's great. Thank you, Roberto. Great talk.
Thank you for doing this, because one article that I came across was actually about the feeling of patients with sarcoidosis, and the paucity of data on patients with sarcoidosis and COVID-19. And so a group in California thought of actually surveying patients with sarcoidosis, and there was a tremendous feeling of lack of information because of the lack of data.
That is true. That is true.
All right, well,
All
I
right.
think
Well,
there is a break now.
okay. Well,
The
thank you
question in
so
the chat,
much. again.
Tanya, there's a question in the chat box.
Yes, yes. So there is a question.
Oh, was there
I'm
many
sorry.
new? Yes, I'm
And
reading.
the question was there many new diagnoses of sarcoidosis with COVID-19 patients?
Well, it seems not. Actually, the two largest case series, which come from multiple nations and they put together, one actually was from India, and India has 1.3 billion people, and also one from United States combined with Europe. They had 24 to 40 cases each that they could put together and describe. So no, it doesn't seem to be that there is an increased incidence. My personal take is that very often patients with chronic diseases or that have to do with the immune system have been way more careful than the general population in going out, using the masks, getting vaccinated as soon as possible. So I think they did a good job in protecting themselves just by doing that. Because the same is for other autoimmune diseases.
All right. I hope that answered your question, Nadine. But okay, if there are no other questions, I'm going to have us go to break to allow.
Actually, if I may, I actually misread the question. I thought the other way around, but the question is actually if there was an increased amount of sarcoidosis with patients that have COVID-19.
Mm-hmm.
So the other way around, now that we know, that would be interesting, but now that we know, certainly there is some increase in scarring of the lung after COVID-19 for a fraction of the patients, but an increase of sarcoidosis that is not come out yet.
Right.
Interesting question though.
Mm-hmm.
More interesting than the previous one that I understood. Yes.
Right.
Thank you.
Thank you. Thank you. I don't know if Nadine was thinking about comparing it to 9/11, where we probably saw more cases of sarcoidosis come up after that. But
yes, that's a very different,
yeah.
very different scenario. Yes.
Yes, yes. So, all right, then we're going to go to break for the next 10 minutes. We're going to restart. Actually, I'm going to say, yeah, just look at my schedule here. Yep, we're going to restart at 3 o'clock. So you got 7 minutes. We're going to do a restroom break, get a drink, and come on back. And we got more to review. We're going to have our talk about what kind of food you should eat when you have sarcoidosis. We're going to discuss how sarcoidosis affects the kidneys, as well as how does sarcoidosis affect the heart. So come on back. We'll see you in 6 minutes.
Thank you again.
All right, we're going to go ahead and get restarted. So at the top of the hour, we have Kirsten Deagle, our registered dietitian here at Temple University Hospital. She works primarily in the pulmonary department with focus on lung transplantation, but she also does specialize in the other diseases that affects the lungs. With this next 15 minutes, she will discuss nutrition and sarcoidosis and what kind of diet you can look at being on with this disease process. Kirsten?
Excellent. Hi, everyone. So we can just jump right in since we have 15 minutes. So you can go to the next slide. So as you guys know, sarcoidosis, the cause is unknown. It affects various areas of the body. It's characterized by granulomas, and the treatment depends on the severity of the disease. So I know Nora just went over some of the treatment medications and things like that. So that's kind of where our nutrition areas are going to focus. Next slide. So nutrition, how does nutrition play a role? So nutrition affects our health overall, right? So there are some foods that promote inflammation and others that are anti-inflammatory. So it also depends on how the disease affects you. So sarcoidosis can affect people in different ways. It can cause fever, fatigue, weight loss. Sarcoidosis in the brain can cause diabetes insipidus, which is different from what people normally think is diabetes. So we'll talk about that. And sarcoidosis can affect the liver and kidneys. Again, as I mentioned, the sarcoidosis treatment. So it depends on what your treatments are and how nutrition can also play a role in those. So some people are on long-term steroids, which can affect bone health, as Nora mentioned, and there's some food-drug interactions, which we'll go over, and immune suppressants and food safety is an area that we'd like to focus on as well. Next slide. So how does sarcoidosis affect you? So fever, if you do have fevers with your sarcoidosis, you need increased fluids. This should be primarily from water. It shouldn't be from soda or things like that, because you really want to hydrate your body. Sometimes you might need other kinds of fluids like that have electrolytes in them. Sometimes people like to have Pedialyte, sometimes Gatorade, Powerade, things like that. Fatigue is also an area. So this may make cooking harder. It may lead to inadequate intake. So that's something to consider. It may also make you less active and start to gain weight. So it just depends on where you're at in that spectrum. It could also cause weight loss. So in those instances, you may need to increase your calories or have higher calorie things. That doesn't necessarily mean go to things like ice cream and candy. You still want to have foods that have a lot of nutritional value to them. Think of ways to kind of get your calories, but also have those nutrients would be like healthy fats, things like that. And sure, boosts are always good things that you can try as well. And in terms of the liver disease, kidney disease, and diabetes insipidus, this may require some special diets. Next slide. And then you want to consider how your sarcoidosis is being treated. So again, these long-term steroid use can lead to diabetes. So you want to make sure that you're getting your lab work checked regularly. It can also affect your bone health. So you want to follow up regularly with your doctor, get bone screenings is recommended. You may also need prescription medications to prevent or treat osteoporosis. You want to make sure you're eating a varied, nutrient-rich diet that includes plenty of fruits and vegetables. Consume calcium and vitamin D rich foods, and ask your doctor about supplementation. Sometimes people don't tolerate dairy supplements, which is a big source of calcium and vitamin D. So you might need to have an oral supplement of calcium and vitamin D. You also want to make sure that you're physically active every day. Keeping your bones strong involves doing activity, and actually ones that involve weight. So I was actually looking up the other day about how to increase the bone density of your hip bones. Stomping actually is one of the ways to do that. So you want to do something that's physically active and actually involves some weight to it. Don't smoke. If you do currently smoke, you want to quit. Limit drinking alcohol. Improve your strength and balance to prevent falls. That's going to be really important for bone health, right? You don't want to have a fall that can cause you to have a, sorry about that, have you have an injury or actually cause those bones to break. And make sure your home is safe from falls. You want to make sure that you secure or remove area rugs. That's number one cause of tripping over things. If you have small pets too, that can be a cause of those. So you just want to make sure that, you know, you keep the pets in a safe area, especially, you know, around stairs, things like that. And use grip bars in the shower. Those can be installed pretty easily, just to make sure your environment's a little bit safer. Next slide. So there are some food and drug interactions. Methotrexate, which you can see the common brands there. Vitamins preparations containing folic acid or its derivatives may decrease responses to methotrexate. Folate deficiency states may increase methotrexate toxicity. So again, this is something you want to work with your team on. The number one thing is don't take any sort of supplements, including vitamins, without letting your doctor know that you're on those or letting your pharmacist know that you're on those. They can always let you know about interactions that can occur. A lot of times people think, oh, it's just a multivitamin, it's fine. But this is a perfect example of an instance where this may affect your medication. Another medication, azathioprine, sorry about my pronunciation. This medication should be taken with food to reduce stomach upset, and it's also associated with folic acid deficiency. And the mycophenolate is also known as Celsep. This should not be taken at the same time as antacids containing aluminum and or magnesium. So again, we don't expect you guys to know if the antacid that you're on contains those things. So just make sure that you're letting somebody know that you're taking antacids or anything over the counter. You know, even if you think it's not a big deal, oh, this is just something that I take on the side, let somebody know that's prescribing you medication or your pharmacist that's providing those to make sure that there's no interactions. Celsep should be taken on an empty stomach unless it's instructed otherwise, because it does affect the absorption, and you want to limit your alcohol while you're on Celsep. Next slide. So immune suppressants are one of the treatments that is used for sarcoidosis. So one of the biggest things with a decreased immune system is that it makes you more at risk for getting sick. And a lot of times we know getting a cold or the flu, but it also makes you more at risk for foodborne illnesses, or some people like to call this food poisoning. The big things here are you want to make sure that you wash your hands before preparing foods. Make sure that you're also washing them before you're eating foods and anytime after you touch raw meat. Some of you may think this is all common sense, but a lot of times these things aren't as common as we think. You may, go touch the fridge and then you put something in your mouth. You don't know, maybe it was a couple hours ago that someone else in your family touched that fridge that didn't have clean hands. So that's why anytime before you're eating anything or you're preparing foods, you want to make sure you wash your hands. You want to make sure you keep cold foods cold and hot foods hot. Make sure you're putting foods away right after food shopping and after meals. Don't go to the food store and then run a couple different errands after that, because you want to get that food back into your fridge or your freezer right away. Make sure that you're cooking your meats, seafood until they're at the proper temperatures. You can look those up online. Eggs should be cooked until the yolks and whites are firm and not runny, unless you can find pasteurized eggs. Pasteurized eggs are eggs that have been heat treated to kill bacteria. They're not as easy to find as you would expect, but those are the only kinds of eggs you should have if you are going to have runny eggs. Make sure that you're heating cold cuts, hot dogs, deli meats, and sausages to steaming before you're eating them if you're on any immune suppressants. I like to think of it as doing like a grilled ham and cheese or a panini, but you don't want to have any cold lunch meats. They can have a bacteria on it called listeria. And don't thaw things on the kitchen counter. You always want to make sure that you're thawing in the microwave or in the refrigerator. If you are thawing in the microwave, just make sure that you're cooking that food right away after that. Next slide. Just some more food safety tips. So make sure you're cleaning your fresh fruits and vegetables and avoid those with bruised or damaged areas. Any sort of cut fruit should be refrigerated. Keep in mind, if you're seeing it refrigerated in the store, that means that it needs to be kept refrigerated at home. Or if you're cutting your own fruit, say it's a pineapple or watermelon, you want to make sure that you get that into the fridge and don't leave that out. Avoid raw sprouts. These are like those fancy little green things that they put on the side of sandwiches. They're not very easily washed and they're a big source of bacteria, so stay away from those. And make sure that you're never cutting any of those fruits, vegetables on the same cutting board that was used for meats or seafood without cleaning it. Don't use any ice that's been used to cool down foods for beverages. So think about it like a cooler. If you have your different drinks in there, they're in cans or bottles. The ice that's surrounding those, don't eat that. Don't consume that. Don't put it in drinks. Have separate ice that's used for eating things. And if you're transporting food that's perishable, make sure you're just using an ice pack for that. Next slide. And that's it for you guys. I know we have a couple minutes if anybody wants to ask any questions.
Yeah, wonderful talk, Kirsten, about the different meds that interact with some of the immunosuppressive meds that the patients are taking. So that was great. We actually have a message that Dr. Gupta put out in the box about he agreed about, would recommend always asking your team regarding calcium and vitamin D if you have sarcoidosis to prevent high calcium, which can happen in patients with sarcoidosis. Now, we have a question from the group, from Deborah, who said, please talk about anti-inflammatory foods. And one last thing from a Kevin in the group, do you recommend fasting and intermittent fasting?
Sure. So some of the anti-inflammatory foods are going to be your healthy fats. So using avocados, some of your healthy fats contained in fish like salmon. Fruits and vegetables are big sources of anti-inflammatory, what's the right word for it? Components or things like that that can actually lower the inflammatory level in your body. Your high inflammation foods are going to be your high bad fat foods, your fried foods, things like that. That's going to increase inflammation. And so is sugar. Keep in mind that sugar, there's natural sugar and there is not natural sugar. People always like, oh, bananas are so high in sugar. That's natural sugar in terms of fruit. And I don't mean in terms of diabetes, this is separate from all of that. But having a piece of candy is much different than having a piece of banana in terms of the inflammatory properties of that. In terms of intermittent fasting, it depends why you're doing it. I don't necessarily believe in it. I think that the right way to approach eating is by having balanced meals throughout the day. And it just really depends. You know, some people are doing intermittent fasting for weight loss. I just don't believe that's the healthiest way to go about things.
All right, Kirsten, thank you so much. That was great. Do we have any other questions?
Somebody has their hand raised.
Yes, that looks like that was Deborah, who had asked a question about anti-inflammatory foods.
Kevin, I see your other comment. I haven't heard of intermittent fasting for anti-inflammatory. Again, I think it kind of depends on what foods that you're eating during the times where you're not fasting. Some people because they're so hungry for all that time, don't make proper food choices after. So that's why I'm not a huge supporter of intermittent fasting. It really, I think if you have a balanced diet of fruits and vegetables and lean meats, then you're doing a lot, then you're getting more balanced diet and decreasing the chance to have some of those foods that cause inflammation.
Kirsten, you have another question from Daryl Rainey. So are you suggesting perhaps 5 small meals daily?
It depends really on what your lifestyle is. My lifestyle when I'm at work is much different than at home. And no, I don't have sarcoidosis, but I do think it depends on what works best for you. I think that if you get full, if you get short of breath from feeling too full, or you're having a difficult time kind of getting through your meals because you're fatigued, then 5 meals a day is a great option to kind of split it up and not overwhelm yourself. But if you're really busy throughout the day and 5 meals isn't reasonable, I think 3 is absolutely fine.
I'm going to take this last question because we're actually at the 3:15 mark and we need to start our next talk. And this is from Terry Robinson. And she's asking, not sure if I heard you say what foods we should be eating.
So basically a balanced diet. So you want to make sure that you are getting some sort of protein with your meals. You want to make sure you're having enough carbohydrates to give yourself energy. And then fruits and vegetables are going to be your main focus. I'm not opposed to having treats. And what that means for me is that it's something that you shouldn't have very often. So whether it's a dessert or something like that, it means that you better enjoy it. And it means that you don't have it as often, meaning maybe once a week, maybe once a month, depending on what it is, versus having dessert after lunch and dinner every day. That's something that I would recommend to avoid.
Well, great. Thank you so much, Kirsten. And remember, everyone, we will have the panelist meeting at the end of the seminar, and hopefully Kirsten will be there so she can answer any more of your questions you have regarding diet. But let's go to our next speaker, which is Dr. Serban Konstantinescu. I'm sorry, Dr. C. I know I probably brutalized your name.
Good afternoon. Tell me if it's Tanya. Tell me if I'm on the right link. I'm on the right link. Can you hear me?
You are on the right link, Dr. C.
Let's see if I can. And you will advance the slide?
There is actually a tech that is on the Zoom that is will advance your slides when you tell them to. But just perfect. So that I can give everyone a quick background about you. So Dr. C is a professor of medicine with the Lewis Katz School of Medicine at Temple. He is actually specializes in nephrology, also with a specialization on kidney and pancreas transplantation, as well as being the head of kidney transplantation. I'm going to turn now the mic Zoom over to Dr. C. Dr. C, once again, when you're ready for the slides to be advanced, you can say next slide.
Oh, perfect. Excellent. Good afternoon to everybody. Oh, good. So actually, so I'm trying to tell that sarcoidosis essentially is a lung disease, and Dr. Gupta already talked about lung disease. Many of the patients who are referred to a kidney specialist comes from the lung clinic. They come with lung symptoms. They have dry cough, they have fatigue, they have weight loss, and obviously they have a normal chest X-ray, and these are the stages of sarcoidosis. I will not spend too much time because Dr. Gupta already talked extensively about the way sarcoidosis affects the lung. Next slide, please. But I want to let you know, as you well know, sarcoidosis is a systemic disease, means it's not localized to the lung, but affects many systems and organs, the skin, the peripheral lymph nodes, sometimes the eye, the liver, the spleen, the cardiovascular system, and you'll have a discussion with Dr. Laslet, the speaker who comes next. And then you can have also cerebral nervous system involvement. Next, click the. Okay, what I will focus on the bottom of the screen, the extrapulmonary signs and symptoms of sarcoidosis, which affect the kidney. Renal means kidney. And about 5 to 20% of all patients with sarcoidosis will have some kidney issues. Essentially, they may have abnormal kidney function. The calcium will be high, and during this seminar, you were you became fully aware about the fact that serum calcium can be elevated in patients with sarcoidosis. Some of you may develop kidney stones or even calcification in the kidney. Next slide, please. Now, so in a nutshell, these are the possible kidney and urinary tract manifestation of sarcoidosis. A patient with sarcoidosis may develop kidney stones and some diffuse calcification of the kidney, which is called nephrocalcinosis. In sarcoidosis, the patient can develop medical renal disease, and I will show you some pictures, even some pseudotumors, and we'll discuss about, and even very, very rare sarcoidosis can affect any part of the kidney and urinary tract. The ureter can be involved, the urinary bladder, the urethra, and even the male external genitalia. Next slide. Now, the major kidney manifestations sarcoidosis is represented by kidney stones and nephrocalcinosis. About 10% of all sarcoidosis patients will have kidney stones. But most importantly, many of the sarcoidosis patients with kidney stones are already diagnosed with sarcoidosis before. Only 2.2%, only a minority of the patients will have a renal colic without knowing that they have sarcoidosis as an initial manifestation of sarcoidosis. 5% of the patients will develop nephrocalcinosis. And the important things, these manifestations are related by the deposition of calcium oxalate, and sometimes the calcium oxalate is mixed with calcium phosphate inside the kidney. Now, many times the kidney stones are asymptomatic. You have kidney stones, but you don't know that you have. Sometimes the kidney stones become symptomatic and you will know exactly you have kidney stones. Significant flank pain, difficulty in urination, and most importantly, blood in the urine. So many times a kidney stone with kidney colic will bring the patient to emergency room. Next slide. Now, so if you look at the right side of the screen, so in the middle, there are two round forms and one form has a white spot. That white spot is a kidney stone on the left kidney. On the right side of the picture, in the middle, there is a rhomboid, and let's say roundish type of structure, which is the kidney in a horizontal section with some calcification, diffuse calcification of the parenchyma. Let's go to the next slide. So now, if you have kidney stones, either symptomatic or asymptomatic, you have to do imaging studies in order to identify the presence, the size, and the number of the kidney stones you may have. Either CT scan of the abdomen or a kidney ultrasound will suffice to put the diagnosis of kidney stones. If you have pain control is essential, and then you'll have to see either a nephrologist or a urologist and to understand what the chances to spontaneously eliminate the stone. And the chances to eliminate the stone will depend on the size of the stone. Small kidney stones below 2 millimeters will be essentially eliminated spontaneously. If the stone starts to grow up to 2 to 4 millimeters, then the chances to eliminate the stones increases to about 80%, decreases to about 80%. If the stone gets to 5-6 millimeters, half a centimeter, then the chances to eliminate the stone is only 50%. So the larger the stone, the less likely that you will be able to spontaneously eliminate the stone. Now, very importantly, if you have a kidney colic, a renal colic, you have to strain the urine and you have to collect the stone and you bring the stone to the lab, and we can obtain what is called stone crystallographic analysis. We'll know exactly the chemical composition of the stone, and we may modify the diet in order to prevent stone reformation. If the stone is stuck in the kidney and cannot be eliminated spontaneously, then there are a few options. One option is to have what is called a shockwave lithotripsy. It's an outpatient procedure. High frequency ultrasound will fragment the stone, and the small fragment of the stone, like a sand, will be eliminated in the urine. If the stone is again stuck in the kidney or in the urinary tract, then the urologist will do a ureteroscopy or even open surgery to take out the stone. Next slide. Now, probably it was discussed during this symposium why you develop hypercalcemia and kidney stone, and the reason you develop hypercalcemia and kidney stone, the reason is the abnormal metabolism of vitamin D. Now, we eat vitamin D in food, mainly in dairy products, in milk and cheese. There is natural vitamin D. Then some of us will take vitamin D supplements. Some of us will go to the seashore and the skin will get exposed to sun radiation, and inside of the skin we have inactive vitamin D, and the ultraviolet light will activate the vitamin D. So either we ingest vitamin D or the vitamin D gets activated through the skin. Cholecalciferol or ergocalciferol, these are the precursor, and inactive vitamin D will go to the liver, will undergo the first hydroxylation, and then in a normal individual or individual with no sarcoidosis, the second hydroxylation of the vitamin D or 3, the process which will activate the vitamin D takes place in the kidney, and kidney is able to regulate the level of alpha-1 alpha hydroxylase. The problem in patient sarcoidosis is that inside the granuloma, the macrophages have this intrinsic capacity to produce large amount of alpha hydroxylase, which will transform the 25-hydroxy vitamin D2 or D3 in active vitamin 3, which is called calcitriol, 1,25-dihydroxy vitamin D. And the presence of this vitamin, which is active vitamin D, will enhance the absorption, natural absorption of the calcium from the gut. You eat all kinds of dairy products, and the high level of active vitamin D, calcitriol, will favor the rapid absorption of the ingested calcium. Next slide. Now, in the second, when you have a lot of absorption of the calcium, then the calcium in the serum will go up. It is called hypercalcemia. So the labs will show that you have high level of calcium, and also because of very high level of calcium, some of the calcium will get eliminated into the urine. And because of the high concentration of calcium in the urine, which is called hypercalciuria, this calcium will precipitate in form of calcium stone, calcium containing kidney stones. So what's the treatment? First of all, you have to avoid sun exposure. You have to avoid calcium supplements, and Kirsten Deagle talked about the nutritional modification you have to do for your diet. You have to avoid also vitamin D supplements. Most importantly, if you get treated for pulmonary sarcoidosis with steroids, the steroids will be able to correct hypercalcemia and hypercalciuria. So the steroid treatment for sarcoidosis in general will be able to control the hypercalcemia, high level of calcium in the serum, and the high elimination of calcium in the urine. Next slide. Now, the second complication of sarcoidosis in kidney is called medical renal disease. In the left two panels of this slide, you can see the granulomatosarcoidosis. And if I will not tell you that is a kidney, a pathologist, if he looks at these changes can appear in any organ. This is kidney, but they will look the same as any organ. The right side of the slide is a special slide for the kidney. Is called the glomerulus. This is a unique filtering unit of the kidney, which can be affected in sarcoidosis, and the inflammation of glomerulus is called glomerulonephritis, like an inflammation of the glomerulus. Next slide. Now, Keep in mind that sarcoidosis treatment is the same whether you have pulmonary disease or you have renal disease. And Dr. Casas from the pharmacology department talked about treatment. The treatment is steroids. On the left side of the panel, first of all, if you have impaired renal function, we'll start with low dose steroids. If the steroids are not effective, then we can use azathioprine, mycophenolate, or infliximab, as was discussed by Dr. Karazas. If you have renal sarcoidosis which respond to prednisone, the prednisone will be continuous weeks and weeks, actually months, 18 to 24 months. Next slide. As I told you, sometimes the sarcoidosis granuloma produce some pseudo tumors, and don't get excited if you get a false diagnosis from radiology, either in the kidney or for a man in the testis. Next slide. And to conclude, the renal manifestation of sarcoidosis are the following. First of all, you have to keep in mind that kidney disease is silent, very silent, except the fact the moment when you develop renal colic. Without renal colic, you are not aware that you have any problem with the kidneys. Nearly all patients with kidney involvement by sarcoidosis have evidence of disease somewhere else. Usually we don't diagnose sarcoidosis. Sarcoidosis patients are sent to us by our pulmonary colleagues. And keep in mind the renal sarcoidosis is very likely underreported. What you do for renal sarcoidosis, nothing special. You have to do the standard labs. You have to measure the vitamin, the 25-hydroxyvitamin and 21 and 25-dehydroxyvitamin, the intact PTH. We do urine analysis. Sometimes you do a 24-hour urine collection to find out the stone risk profile and whether you are leaking protein or not. Very rarely we do a kidney biopsy for medical renal disease. And most importantly, we do imaging tests in order to diagnose the localization and the size of kidney stones. Next. Now, there is any chance that the kidney sarcoidosis will progress to end-stage kidney disease is very rare. Is very rare, very rare. A kidney disease patient, a patient with kidney sarcoidosis will end up on dialysis. Usually, if a sarcoidosis patient will develop end-stage kidney disease is because of other reasons, diabetes or hypertension. Nevertheless, if you develop end-stage disease, we can help you doing hemodialysis, peritoneal dialysis, or kidney transplant. And keep in mind, the steroid treatment is the mainstay therapy for calcium abnormalities and all sarcoidosis-related medical renal disease. Thank you.
Thank you so much, Dr. C, for that wonderful presentation on how sarcoidosis affects the kidneys. It's really good to hear how the patient should absolutely avoid calcium and vitamin D unless advised by their provider because of the way it can affect the kidneys. Hopefully you'll be joining us in a few more minutes when we have question and answer session at the end. Our next speaker is going to be Dr. David Lassett. He is an assistant professor of medicine with the Lewis Katz School of Medicine at Temple University. He is a cardiac electrophysiologist that also is here to talk to us today about how sarcoidosis can affect the heart and what kind of things can happen, such as what we call arrhythmias or that irregular heartbeat. Dr. Lassett?
Hello, can you hear me?
Yes, we can hear you.
Wonderful. Well, I just want to say thanks to Dr. Gupta for having me. I really appreciate it. It's really exciting that these things are being done, these seminars, and with the focus on the patient. I think it's awesome. So I'm very excited to talk a little bit about cardiac sarcoid, which is the name of sarcoid that affects the heart. And again, my name is David Laslett. I'm a electrophysiologist, which is a heart doctor that deals with abnormal heart rhythms and things like that, which is really can relate to sarcoid, as you'll see. Next slide. Click next. So this is just showing the patients that if you do a literature search, I'm sorry, I turned my video on. Oh, whoops, I'm sorry, my camera's not working. I apologize for that. This is, if you do a literature search and look for cardiac sarcoid, which is again, is sarcoid affecting the heart, you'll see that there's been a dramatic increase in the number of articles about the topic over the past years. And a lot of this is just increased recognition, and it's a really hot topic, and there's more and more known about it, so it's a very exciting time to study this disease, and that reflects in the literature. Next slide. Next slide. Sorry, you have to keep clicking. Next slide. Here's another slide just showing a similar theme. This is out of Finland, showing just the number of cases of sarcoid in their system over time, looking at 4-year chunks. And part of this, again, is just increased recognition. We're more aggressive at diagnosing sarcoid. There is some thought that maybe there's increase in an environmental factor that unclear exactly what, that may be actually promoting higher rates of sarcoid too, but a lot of it is probably just increased detection. Next slide. So this is a very simplistic model of the heart. And you see there's 2 top chambers here. Does my arrow show up? Can you see my arrow or no?
Yes, it's there.
Wonderful. So yeah, and stop here. So this is the 2 top chambers and 2 bottom chambers here. The bottom chambers are the main pumping chambers of the heart to do all the work, okay? And these top chambers pump blood into the bottom chambers, which then pump blood out to the rest of the body. This yellow line you see here represents the heart's electrical system. And the heart knows to beat and contracts because there's an electrical system. There's a bunch of, basically you can think of it like long fibers or cables that carry electricity throughout the heart and deliver it to every part of the heart in sort of a simultaneously fashion. And this electricity causes the heart to contract and beat. Sarcoid can affect various parts of the heart. First of all, it can affect these electrical cables, these yellow lines you see. It can damage them and actually lead to a dangerous slow heart rhythm because the electricity is not being delivered to the heart. And the heart can only know to beat because of the delivery of this electricity. So if you damage it, you may lead to a dangerous slow heart rhythm. The heart doesn't beat because it's not being told to. Sarcoid can also affect the heart muscle itself. A heart is just a big muscle, and it can damage the muscle and make it weak, and that can lead to congestive heart failure. And finally, the inflammation and damage and scar that can occur in the heart can also lead to dangerous heart rhythms that come from these bottom chambers, extra beats or fast heart rhythms that can be dangerous. So we'll talk about that more as well. Next slide. And how common does it affect the heart? It can be common. And in fact, in studies, it's probably more than 25%. But if you look at patients that have known sarcoid affecting other parts of the body and you do advanced imaging or on autopsy data, you'll see that there is an effect on the heart or involvement of the heart in at least 25%, probably more of patients that don't yet have obvious symptoms related to the involvement of the heart, but it's there if you look for it. And then there are even cases that only affect the heart. And that can happen in 25% of cases that affect the heart, only affect the heart. And actually those can be the most severe cases leading to heart problems, which is what we've learned from studying this over time. Next slide. Next slide. We'll stop here. So I just want to go over some of the symptoms that you can experience if sarcoid affects the heart. One of the most common ones is palpitation. So this is a sensation of your own heartbeat, and it can be extra beats, skip beats, or even a racing heartbeat. And this can be caused by extra beats from those bottom chambers that caused by the damage from the sarcoid, and those are called PVCs, or fast, dangerous heart rhythms that come from those bottom chambers, and that's called ventricular tachycardia. And you may just feel your heart racing. Another possibility is you may pass out or have episodes where you get close to passing out. And that can also arise from these dangerous fast heart rhythms in the bottom chambers. Or, as I talked about before, from damage to the heart's electrical system, which can lead to dangerous slow heart rhythms, both of which can cause you to pass out or get close to passing out. Next, please. Or a severe presentation would be from either the dangerous fast rhythm or that dangerous slow rhythm, that your heart stops completely and you have a cardiac arrest, where in order to be revived, you actually need either to be shocked from a defibrillator or from pads applied by a paramedic if you had a dangerous fast rhythm, or you need an emergent pacemaker if you had a dangerous slow rhythm. Next. And then finally, you could experience shortness of breath, which can happen when you exert yourself or at rest, leg swelling, abdominal swelling, fatigue. These are all common symptoms that patients get with heart failure. And that arises from, can arise from sarcoid damaging the heart muscle itself, causing the heart muscle to be weak and then leading to congestive heart failure. And those are the most common symptoms of congestive heart failure. Next. So how does this happen? Why does this happen? From all the other talks, it should be a common theme. This is from inflammation. So these are the same white blood cells that are used to fight infection. Instead, throw a party in our organs in this condition and cause damage to our own organs when it's not supposed to, obviously. And if you look under the microscope, you see this thing called a granuloma. If you look in any organ, you'll see it. These are a bunch of white blood cells causing inflammation. And if you don't treat it, this inflammation over time turns to scar. And scar is what actually permanently damages the heart. You don't want it to turn to scar because you can't recover from scar. Once there's scar in the heart, that's there forever. Next slide. So how do you diagnose sarcoid in the heart? Well, you start with some basic tests like an EKG, a heart monitor, an ultrasound of the heart called an echocardiogram, and you can get clues based on those studies. And then if you suspect it based on that, then you proceed with the best test that we have, which one is called a PET scan, where because the cells, those white blood cells that are causing the inflammation are hungry for sugar, you can give a special radioactive sugar molecule. And you have to do a special diet before this test. But when you give that, it goes to where those white blood cells are. If they're present in the heart, they'll take up that sugar that you give through the IV. And then it lights up on the scan. So you see these areas of really light glowing signal. That's where there's active inflammation from those white blood cells inside the heart muscle, and it's taking up the sugar, the radioactive sugar that you gave through the IV. So this shows an example of someone with active sarcoid in the heart causing inflammation. Next. Here's a picture of an MRI, so the other very helpful test. This is the chest. Inside the chest here is the heart, and you'll see the heart muscle is this black thing here, and you'll see these bright areas of white inside the black, which is not supposed to be there. That's an MRI, abnormal MRI, that shows areas of scar and/or inflammation. It can see both inside the heart, and that is what can be seen with sarcoid. Next. So I just want to show a few slides real quick to show you how different this is than some of the other common diseases of the heart that we deal with. This is a patient, this is a section of someone's heart. It's sliced basically in half. And people that have a heart attack, which is the most common heart disease we see, they form a scar. You can see this is the main pumping chamber of the heart here. And you can see this white area. This is scar. If you have a heart attack, the heart muscle turns to scar. But it's in a specific area of the heart, on the inside of the heart, and in a specific regional area distribution that we expect based on where the heart attack is. And it's reproducible. We know where to look. We know where the scar is going to be. Advance forward, next slide. One more. Great, here. So here's a heart with sarcoid. Now you can see these same areas of white, which I'm highlighting with the red and with my arrow here. The heart muscle is normal, sort of red, and you see all these white areas all throughout in both bottom chambers and in a random kind of patchy distribution, both on the inside of the heart and on the outside layer of the heart, and even in the middle layer of the heart here. So it can be in any layer of the heart muscle, in any chamber, predominantly in the bottom chambers, either the right or the left. Remember, you have two bottom chambers, and it can be random and patchy. So it actually is a lot harder to, that makes it in some ways harder to treat. And also, if you were to do a biopsy of the heart, you may miss it. You may biopsy a piece that is healthy because it's not everywhere. It's sort of random, and it may be on the outside of the heart, but you're biopsying the inside of the heart. So it can make it challenging to both diagnose sometimes and treat. Next slide. So perfect segue. And how do we treat sarcoid when it involves the heart? Mainstay, like you've heard in all of these other talks, is immunosuppression. So medicines that treat that inflammation, that decrease the inflammation, steroids, methotrexate, other medicines. A pacemaker or a defibrillator, which I'll show you a picture of, is an implanted heart device that is needed if you have damage to the heart's electrical system, which I showed you can happen, or those dangerous fast heart rhythms that can occur from the bottom chambers. It's a treatment for both. There are also medicines that can treat or suppress abnormal fast heart rhythms or abnormal extra beats from the bottom chambers. These are called anti-arrhythmic medications. And sometimes we use them to try to prevent those dangerous heart rhythms or extra beats from happening in the bottom chamber, because they can be dangerous. And if you have a lot of extra beats, they can even cause you to feel sick and have heart failure symptoms. And then finally, another big topic is actually an invasive procedure called an ablation procedure. This is a procedure where we put catheters, basically like a long tube, up into the heart. Actually, we put them into the veins and arteries in the upper thigh and then pass them into the heart. And one of our catheters has a long metal tip that we can use to cauterize tissue. And we try to put them in the catheters in the area of the scar that I showed you on the section of the heart. And we try to cauterize those areas of the scar that are involving and causing the dangerous fast heart rhythms. So it's a way to treat the dangerous fast heart rhythms that are happening from the bottom chambers. Next. So here's, I just want to show a couple quick examples of treatment. Now, I told you the mainstay of treating sarcoid that involves the heart is to prevent, to treat someone before they form a lot of scar, because the scar is what is irreversible and permanent damage. So this is a PET scan and shows this bright white stuff is all the active inflammation. It glows. This is where all the inflammation is happening in the heart muscle, where all those white blood cells are. Put the patient on steroids and look over here where there's much less white. It's glowing much less. So the steroids are working. The inflammation in the heart is becoming a lot less. And hopefully this will prevent the formation of scar. And this is reversible. It can even lead to improvement in heart function, decrease in the amount of extra beats or dangerous heart rhythms coming from the bottom chambers. So it can be very effective. Next. Here's yet another example. There's a little less glowing to begin with, but this is active inflammation. And then with steroids, it goes pretty much completely away. There's no active inflammation in the heart on the PET scan, which is great. Next. Here, I promised I'd show you a picture of what a defibrillator pacemaker is. They have every defibrillator has the ability to be a pacemaker too. I know it's a confusing word, but it's a heart device. You have a battery that's under the skin in the upper chest, and 1 to 2 wires that go inside the heart, and actually they get plugged into the heart with a little screw, they get attached to the heart, and they provide the heart electricity if a situation where there's damage to the heart's own electrical system, so it can make the heart beat if the sarcoid is damaged to the heart's electrical system so that it can't beat on its own. That's the pacemaker part of it. And then the defibrillator part of it, if the heart has those dangerous fast heart rhythms from the bottom chambers, it can treat them either by pacing the heart really fast or by delivering a shock, which can happen very quickly, and so that you wouldn't have to wait for a paramedic to show up, which could be too late. So that's the purpose of it, and it's a minor surgical procedure to put that in, and the battery lasts about 10 to 12 years. So it's great. You get it put in, and then 10, 12 years later, you just get a battery change, and that's how that works. And next, and finally, I wanted to show this last slide as one of the advanced treatments of sarcoid, because sometimes, let's say a patient presents late and they've had sarcoid for years, but they don't get diagnosed until late, and now there's already a lot of scar in the heart, and the heart's really damaged and it's weak, and the patient has bad congestive heart failure. They're really short of breath, they can't walk at all, and the heart is just a lot of scar. You can't do much sometimes with that, and in those situations, when it's very advanced, we consider these advanced therapy options. Temple's a specialized center, and we do both of these. One is called a heart pump. The shorthand is called LVAD, and it's an actual pump that you implant in the heart that pumps blood for the heart. It's basically like a heart, but with a metal pump. It helps the heart pump blood and takes over some of the function of the heart. It's a major surgery, but you have this permanent device inside you, and you have to wear some batteries sort of around the waist. But it can be amazing how much it helps patients. And then the other is a heart transplant. So we take your old heart out right here, and we put a whole new heart in and connect it to all the blood vessels that are in the chest. It's obviously a major operation, one of the most major you can have, but it gives you a brand new heart. Sometimes we have to do that, and patients can do amazingly well with that. And now you have a fresh heart that has no scar in it, and you have to make sure it doesn't develop any issues over time. And you have to be on a lot of medications, including medicines, immunosuppression, to decrease inflammation. But sometimes that's what's necessary. That's the last slide I had. Thank you so much.
Thank you so much, Dr. Laslet, for all that informative information about how sarcoidosis can affect the heart and cause arrhythmias based on where these granulomas can actually appear in the heart. So now we are actually going to have question and answer session. If I can get all my panelists that are still here present back on the slide.
Here we are.
And it looks like I am already getting a question. And this is actually from a Denise Houlihan. And I know Denise, hello, darling. She wants to know if I am able to be an organ donor if I have sarcoidosis.
You want me to give a
Yes,
try?
Dr. Gupta, why don't you take that question?
Yeah, it's an interesting question. This question was asked to me actually by one of my patients as well. She had sarcoidosis. She has sarcoidosis, and she wanted to donate her kidneys to, obviously one of actually her friends or some family member. And she asked me this question. She actually was very functional. She did not have any symptoms, but she had a lot of nodules. Like you could see on her chest imaging that she had disease. There's no question about that. With respect to kidney numbers, she did not have any high calcium or any kidney dysfunction. But the question is whether she could have this, silent phenotype, as Dr. C alluded to, and as we all know, many of these patients, many of you guys have disease inside which was caught when you were asymptomatic, and we did testing for some other reason, which is called incidental finding. So the question becomes whether that patient or whether you, Denise, have in that organ per se, you have the sarcoidosis granuloma or inflammatory cluster of cells. And from what we know, sarcoidosis, let's say, even when we transplant lungs, the disease can reoccur in the new lungs as well. So most likely the disease is there in the body, in the organs, and some cells in the blood as well, which can recur. Now, in the transplant candidates, we don't have a major problem because they are generally on some medications to suppress the inflammation. So it doesn't really become a clinical problem. Now, if you give that organ to someone who does not have sarcoidosis, what would happen? So there are two things, and I don't think there is great data, and I'll ask Dr. C about this, his opinion as well in a little bit. But from my clinical standpoint, one, if let's say what organ you are donating has the disease, and when you give that organ to someone else, because they will be on the immune suppressant medications, the disease might be silent. And again, before giving that organ, we test the organ many a times by different ways. And if we find that there is no evidence of major dysfunction because of sarcoidosis, it should be okay. That's number one. Second, the other concern sometimes some patients, some clinicians have raised, what if that organ cells go in the system and then the patient can have systemic sarcoidosis? That probably does not happen. So in my opinion, if you do not have a major organ dysfunction because of sarcoidosis, that organ can be used. But this area is not very extensively researched, and most of the transplant centers would probably not take that organ. But I'll ask Dr. C what is his opinion on this.
I agree with you, but I will say that, look, I'm a multi-organ donor. I don't plan to die on the highway today or tomorrow, but if I die a healthy individual, they can take all the organs from me. Now I will speak about the kidney. So I told you that sarcoidosis means for the kidney stones and some inflammatory disease in the kidney. So I think that we can eliminate easy the presence of kidney stones, because
CAT scans.
Before even consider a donor, the patient is in ICU, is sick, they get a CAT scan of the abdomen, so the presence of kidney stones will be diagnosed very easily. And even if you have one single kidney stone on one kidney, that kidney can be used as a kidney donor. Second, if there is any suspicion, we request a biopsy of the kidney, and the biopsy of kidney will tell us whether there is any type of medical disease related to sarcoidosis. Third, we know the function of the kidney. So as long as Dr. Gupta told us, if the kidney, I'm talking about kidney, organ function is normal, there are no specific sarcoidosis related pathology found in that organ, I think that organ can be transplanted. Now, if you have any type of suspicion, always you have to match the organ, the donor with the recipient. For instance, I will not put an old kidney with sarcoidosis, so somebody who has, let's say, 6 years old has sarcoidosis in a 15-year-old child. But vice versa, if I have a young patient with sarcoidosis, God forbid, has a car crash and becomes a multi-organ donor, yes, an adult or let's say oldish recipient can receive an organ. Because always when you do a type of organ transplantation, you look at the quality of the donor and also the life expectancy. 40 years ago, I had a different life expectancy. Now I have a shorter life expectancy because I'm getting old. So transplantation will not make you younger. So always you have to match the life expectancy of the recipient with the quality of the donor.
That's a great answer as well. So again, seeing organ function, and if there is suspicion, kind of testing further, including up to a biopsy, to ruling out involvement in that organ itself.
Okay, great. So we have several questions. So I'm going to actually pick someone to answer each of the questions so we can get through them all. Actually, this question is going to be for Dr. Laslett. Is AICD easily replaced? How long is it typically effective for a heart block?
Yeah, great question. So the ICD, which by the way, if you have heart block, which is when the sarcoid damages the heart's electrical system and you need a pacemaker, in those cases, if you have sarcoid in the heart, we give you a defibrillator too. So that extra functionality that can treat the dangerous fast heart rhythms that can happen, even in patients with heart block. So you would get a ICD as the shorthand for it. And we put in the wires. The wires themselves can last forever. I've seen them last 30, 40 years, even in patients that have them in that long. So often you just have to replace the battery, and the batteries now are lasting, we typically said 8 to 10 years. We have some batteries now lasting 15 years. If you have heart block, you're going to use the pacemaker part of it a lot. So maybe closer to 10 years, but it's a simple, very minor procedure in 10 years to replace the battery. It takes about 45 minutes. And yes, it's possible that if one of the wires gets damaged over time, you have to replace that wire. And that can be a more involved procedure, but we do that all the time. It's a center where we can do that very easily. But otherwise, it's just a simple battery change, and that's very easy. And you could have, if you're 50 and you get a defibrillator pacemaker, and then the wires could last till you're 90, and you just get a battery change every, let's say, 12 years, minor procedure.
Okay. My next question I'm going to pose to Dr. Gupta. Someone wants to know, if you already have a sarcoid doctor, but not at a center of excellence, what is the advantage of being a patient at a center like yours?
Great question. And I always say, sarcoidosis is a disease. If your clinician knows how to treat and is very keen and really listens to you and looks at all the organs, anyone can treat sarcoidosis. The issue is we should have the time and commitment to do so. So if your regular doctor, let's say your primary care doctor, or even a specialist, a rheumatologist, pulmonologist, kidney doctor, any type of doctor, if they're looking at all the possibilities of organ involvement, if they're just being vigilant about the common things, we are checking for your heart rhythm, we are keeping an eye that your eyes are okay, we are making sure that you do not have this hypercalcemia, hypercalciuria kind of stuff. If someone can keep up to that, that's fair. That person can see you, that physician can see you. Now, so that's one, depending on the clinician. Second, in a center which is a sarcoidosis center of excellence or a sarcoidosis clinic, you have a team where many a times if I need to send a patient to a cardiologist, I pick up the phone, I get them included in their patient panel very quickly. And secondly, as the experience increases, because this disease does not have too much of evidence, a lot of things are expert opinion based plus experience based. So as our experience increases, our care improves as well. Finally, when we have these centers have research as well available. This disease does not have a lot of evidence, as I just said. So when we have patients who are suffering from a disease and we need to do something about them, we many a times put them in studies, and studies don't mean that you are being experimented on. You are being carefully studied. For example, if there's a medication and placebo, we're trying to chalk out the differences in the effects of both, carefully monitoring your clinical response, carefully monitoring everything else, and then we are deciding. And with these trials, the field will become more individualized management wise, rather than whoever wants to do whatever. So I think those 2-3 points I would say are the most important for being involved in with a multidisciplinary center.
Okay, great. Dr. C, I have a question I'd like you to take. The last two questions I'm going to open up to, at least that I have so far, I'm going to open up to all three physicians. But for this question, Dr. C, this person, Terry, wants to know, do you know exactly what causes sarcoidosis?
The short answer, we don't have a very good understanding, yes? So the exactly cause of the sarcoidosis is not known. Obviously, there are some of us will have the propensity to develop this type of granulomatous disease, but I cannot pinpoint saying this is a virus or a bacteria or an environmental exposure. No, I think it's an idiopathic disease in terms of cause. Dr. Gupta, please feel free to make any comments, because you run the largest sarcoidosis clinic in the center of excellence.
No, I think this is I think fairly appropriate, but I do think that as time passes, as we are increasingly having more models, we probably will find some triggers. Now, what we as a group of people who are experts in the field, we all kind of are on the same page, finally saying that this is probably not one trigger. There are probably different things which can set off that inflammatory cascade in patients who are already susceptible because of their genes or something like that. And then they go on to develop sarcoidosis. So unfortunately, we do not know what the triggers are right now, but it is possibly some sort of infection, some organic or inorganic particles. One example is actually in a lot of patients after World Trade Center calamity, we have seen an increased number of patients with disease which is very similar to sarcoidosis. So there definitely some sort of environmental factor which is playing a role in genetically susceptible patients.
All right, now for Dr. C, Dr. Gupta, and Dr. Laslat. The next two questions, we'll start with the first one, and this is from Nadine. My husband was recently diagnosed with sarcoidosis through a biopsy of his salivary glands. He is on steroids, and as he lowered the dosage to around 20 milligrams, he seemed to feel the inflammation come back. My question is, if someone with sarcoidosis that affects the salivary glands, is the inflammation considered a temporary flare-up that if treated with steroids could go away at some point and have possible flare-ups in the future?
Who do you want to take this, Tanya?
I'm going to leave that open to the floor, meaning you, Dr. C, or Dr. Laslat.
I will say so. Unfortunately, sarcoidosis can affect any organ. And during our presentation, so yes, 90% of the cases are lung. The patients will present in the lung clinic. but it doesn't mean that you cannot have extra pulmonary manifestation, and there is no organ or tissue in the body which cannot be affected by sarcoidosis. So, and no matter where the tissue is involved, steroid therapy is the first step of therapy. If you fail the steroid therapy, then there are some other options for immunomodulation, like azathioprine, mycophenolate. However, each time when you escalate the dose, you have to weigh the risk and the benefits or the side effects or each immunosuppressive medication. So for many of the participants who took long, high dose, weeks and months of steroids, yes, steroids have side effects, but also the other medication have side effects. So as long as the disease is localized, I will use a minimal therapy possible. If then they will have multi-system organ, then we can escalate the therapy. But keep in mind, sometimes if you develop sarcoidosis in the salivary gland, you may develop later in life, and I hope not, later in life, other system and organ involvement.
And that is the value of having someone who is keenly looking at the patient and examining. Now, the other part of the question was, would that be considered a temporary thing or would it be a recurrent? Again, as I tried to show in that initial graphic, some patients would have a setup where they would have active inflammation. It would go away with treatment or without treatment and would never come back. Some patients, on the other hand, would have this relapsing, remitting type of nature of disease where the disease would come back. You might need treatment or not, then it would go away and it can come back again. So it all depends on the patient's interaction with the disease or the disease interaction with the patient, however you want to put it. But everyone's trajectory might be different.
I'm just going to echo what both of them said and what Dr. Gupta just said about the importance of close follow-up and monitoring. And we've had a couple patients in the last month with sarcoid of the heart, for instance, and they both, it's a good case study, but they both had their steroids stopped completely for, just as what this patient was mentioned, they had thought to have a flare-up involving the heart with some dangerous heart rhythms, were put on steroids, got a PET scan that showed that the inflammation in the heart went away. But then their steroids were stopped. They didn't see, follow up with the doctor for over a year, and no PET scan was done with them off steroids. And then they came back with another really bad flare-up with really dangerous heart rhythms, really sick, and not on any medicine. So it just highlights that importance that yes, you can have recurrent flare-ups and disease, and it really requires close monitoring and being at a good place like this, where you have multiple doctors in different fields and working together, but specifically just keeping a close eye on the patient. If I'm seeing someone with sarcoid of the heart, actually, even if they don't have any evidence of lung disease, I've been referring them to see one of the lung doctors because I think they're better at treating sarcoid, and I like the multidisciplinary approach. But it also has more eyes on the patient, and hopefully prevent patients that fall through the cracks and have these recurrent dangerous flare-ups.
Excellent. Last question I have is, are systemic sarcoidosis patients more susceptible to stresses such as emotional, physical, that result in flare-ups or more active disease?
I can take that, Tanya, if you want. So, this is one of the areas which has been not answered. There are a lot of fields in sarcoidosis which are currently very open, widely open for research and answers. One of the areas which we are trying to figure out are these patient-oriented questions, right? So symptom-wise, quality of life issues, stress, how things precipitate things and all. Again, we know, what we breathe, what we eat, what we drink is what we are, and how we live our life, how stressful our life is, and things impact our immunity and inflammation. So not the greatest data in sarcoidosis field, but we have some data in other metabolic diseases that when you are under stress, when you have not only just emotional stress, but also stress on body with respect to diet, inflammatory diet and stuff like that. It can lead to more inflammatory phenotype in your body, raise the inflammation. So I always say proper sleep, proper nutrition, exercise, or whatever you can do. Again, we understand many of our patients are disabled because of the symptoms, but again, whatever the patient or the person's capacity is, and being involved, being engaged is very important. So the answer to your question is very difficult, whether stress can have more flare up. But I think more and more as we are learning about chronic diseases, inflammatory diseases, even metabolic diseases, we are understanding the value of a good lifestyle and to try to lower your stress, however it may be for you, meditation, exercise, good sleep, sometimes psychology help. It's fine. I mean, again, things take a toll on your body and on our bodies, everyone's bodies. So we all have to look out for our health, and hopefully that can reduce the inflammation. That's what I would say. I don't have a scientific answer, but this is what the clinical theme is.
All right. Well, if there are no further questions, I am going to thank all of our panelists for the wonderful talks that they provided. It was very informative. It educated all of us, all of our patients, people new to the disease process, people who've had it. And it's such key information dealing with the lungs, the heart, the kidneys, the meds, rheumatology. We just had so much information. So thank you everyone for participating. And keep in mind, the Temple Lung Center is here for you through all of your disease process with your sarcoidosis, and not just for your lungs, but we're also here to get you to the right path or the right provider to get your sarcoidosis treated, whether it is through our nephrologist, our cardiologist, the nutritionist, the pharmacist. We are here. Also, keep in mind, we do have a sarcoidosis support group meeting in which we meet every other month, in which our next meeting will actually be on June 20th. You can actually find that on our website through the Temple Lung Center. We wish you all the best. Take care and have a wonderful afternoon.
Thank you, Tanya, for organizing this.
You're
Thanks so much,
welcome.
Tanya.
You're welcome.